Thank you, Peter, and thank you, Samir, for inviting me today. It was more than half a year ago that I accepted to give a talk comparing these different guidelines, and back then I thought, sounds like a nice idea, compare a couple of tables and talk about that for 20 minutes. And after starting, I noticed, well, actually they wrote quite a lot of text. And so I found myself digging through hundreds of pages of text and spread across more than a dozen documents. And I started wondering, we have these three guidelines, and then many of the different countries have local guidelines, and maybe if you have an ABS team, you probably have hospital guidelines on how to treat a fungus. And so I started wondering, is this really something we all use in our day-to-day practice? So I brought a couple of questions that you could answer to me maybe, and it would be nice if you maybe look out for these little devices you have in your places. Because I will start with a question. And my first question would be, if you had to choose one, and of course I know it's always a mix of different aspects you will take into account, but if you had to choose one guideline based on one special feature, and if you knew all guidelines are more or less current and are updated every 3 years, would you use the guideline with the most robust methodology, or would you second use the most comprehensive guideline that really covers all the issues there are? Or would you use the most recently published guidelines, because even in 2 or 3 years a lot can happen? Would you use the guideline that best fits to the patient you're about to treat, like maybe the ECIL guideline for the leukemia patient? Or would you recommend using the local guideline, because the epidemiology of fungi is quite different from place to place? Please vote. Okay, as I expected. Okay, so okay, you think 3 years is current enough in the antifungal sector, which I agree, but otherwise the votes are pretty evenly spread across the different possibilities. Okay, moving on. So actually, I was asked to compare 3 different guidelines. However, updates in 2016 and 2017 were only in the ECIL and the IDSA guidelines. I still compare to the ESCMID guidelines. Oh, and I actually on my slides you will find ESCMID, but I am very aware that the ECMM played a major part in writing that guideline, and so please, if you're from the ECMM, don't be mad at me for not writing both societies on each page. Now, I know that there's probably some of the authors of these guidelines in the room, so I thought I need some rather objective way to appraise those guidelines. I'm not part of any of those. So I was looking for literature and actually found something in the German medical journal, where they did a systematic review of guideline appraisal guidelines, and found like 10 different appraisal schemes you can use to rate the quality of a guideline, and they came up with some rapid assessment criteria that you can use in a bedside manner to see whether your guideline is nice or not, because these are questions that all of the different tools use to make their conclusion. And that is basically, did they have a systematic analysis of the literature? And this is actually something that's quite a lot of work, and usually requires the guideline team to have substantial resources to go through all the literature and put it into evidence tables. And so this is something you only see rarely in guidelines, but well, they think it's very important to do that, because otherwise there could be bias by pre-selecting the literature. Then they want to see the association between the recommendation and the literature that it's based on. They want information about why the guideline was developed and what the purpose of the guideline is, and they of course want the guideline to be accessible so that you really can understand what it's actually recommending. Now, another question for you. aiming at how you use guidelines, because sincerely, I read all these guidelines when they appeared just to check whether I'm still up to date, but I didn't really go through them line by line. And after reading them first, I must admit I didn't keep looking at them all the time. So I wonder, how do you use guidelines, practice guidelines in the antifungal sector? And the first option being to determine actually most of your treatment decisions. And if you're not sure what the guideline says, you will go back to the guideline again. Or you use it to inform other physicians, maybe at the department meeting or on conferences, to stay up to date for yourself with new developments, to treat fungal diseases you rarely encounter, or you do not use guidelines regularly in your day-to-day practice. Please vote. Okay, so about 1/3 use them in a similar fashion as I do, to stay up to date, to look for new developments that maybe you've missed in your, but 1/3 use them actually for the day-to-day care. Yeah, so that's really interesting. Okay, thank you. Okay, so by these easy questions that were suggested by the paper I just showed you, this would be my quite arbitrary conclusion on the 3 guidelines I reviewed for today. As far as I understand, none of them used systematic literature research or was able to publish their method of searching for literature. So that would be a shortcoming, but I think a very excusable one, because, as I said, it really takes a lot of resources to do that, and I'm not sure if it really would have changed any of the conclusions those guidelines have made. Then how was the connection between evidence and the recommendation that was actually made addressed? I think all guidelines do that pretty well. I think there's a certain detachment in the ECIL guideline, because you have an introductory text, and after then it goes over to tables. The tables do not really, they have no real tight connection to the evidence that has been provided, and so I gave them a plus less, but you might decide differently. That's just my personal take when I was comparing those documents. And the evidence and the recommendation shown is really a very similar criterion. Regarding accessibility, I found that really difficult, because I think all 3 are quite accessible, and I really understand why they chose the way they presented their data, but there are substantial differences. For example, the ESCMID guidelines really try to be very sharp in their recommendations, and so you will have one table, for example, saying you might use this drug to prevent antifungal infections from occurring in patients receiving hematopoietic stem cell transplantation, and then you will have a letter and a number which tells you how good the evidence is, and then on the next page, and then you will think, okay, yeah, well, I might use that drug, and then on the next page you will have the same table, but this time it's not preventing the fungal infection, but preventing death. So you start rethinking, okay, it's not preventing death, but it was, But it's very sharp, and it's very close to the evidence, and so it's very, I think it's very good in avoiding bias in presenting the data like that, but it's not really accessible. The IDSA has a very different approach. They provide recommendations in common language, so it's a very long text that you read. They actually explain what they are recommending and then provide the evidence in the text body. And so it's really easy to read, and I think it's very clear on what they mean. So you could say that's very accessible. On the other hand, if I just open the guideline and want to see, okay, I have this fungus and I want to treat it, how should I do it? You actually have to go through a lot of text and to find the right position. So you could also say it's not very accessible. It's really, it depends on where you are standing and on what you're expecting. ECIL, again, is quite accessible because they really have these clear tables, and they say invasive or candidemia, and then a table of all the possible drugs, and then the recommendations. So that's really quick to go into. But as I said, this is arbitrary. This is my take that I have made. Then I try to check for all the areas they covered, and if you're part of one of those guidelines and I missed something, I'm really, really sorry. It was really a lot of text, and I got dizzy at some point, and it could be that there is a minus where there shouldn't be one, and in that case, I'm happy if you politely notify me after this talk, and I can correct that. I think comparing these guidelines, which is my major task today, the ESCMID guideline on aspergillosis really did an outstanding job in being very comprehensive. And what really struck me is that they really have provide recommendations on all the laboratory procedures as well. So how should a sample be obtained? What should the microbiology lab do with that sample? How can it be stored? And this is special, and I think this isn't met by any of the other guidelines. And I think in aspergillosis, the IDSA did the biggest effort in trying to give some recommendations on the issues that we don't have nice evidence about, and to give a small statement at least. For example, can a patient who acquired an invasive pulmonary aspergillosis continue chemotherapy, and when after this diagnosis? So it's, on the clinical part, they are a bit more comprehensive than the others. The ECIL guidelines, well, the ECIL the current ECIL guideline only goes on treatment, so you have to combine the various publications from the last years to cover most of the issues, but they are still quite current and quite comprehensive as well. Okay, my final question to you before we get into the dirty details of the recommendations. If you had to choose which guideline you recommend, I think this is not the same question as the first one. I'm sorry for that. So I think the third question probably got lost somehow. Okay, well, I will ask you on the break. So this is the grading and system and the level of evidence that the guidelines used. The ESCMID and ESCIL guidelines are pretty similar, so they actually use a grade with a letter, and A is very good, and C is basically not recommended. Some use, say we are strongly against something. The ESCMID guideline uses letter D to be against something, and then there's level of evidence, usually meaning level 1 means randomized trials, level 2 other kinds of trials, and level 3 opinions of respected authorities, briefly. And then the IDSA uses the grade system where they have a level of evidence, where they say observational, non-interventional studies have a low evidence level, randomized or interventional studies have a high evidence level, and then this level is modified by certain criteria, and then they have a grade of recommendation which is strong or weak. To make them a bit more comparable in the tables I will show you later, I present these in a similar fashion, meaning very low is 3, moderate 2, high 1, and strong is A and weak B. So I think it's quite similar. Okay, regarding diagnosis of aspergillosis, you can see that the guidelines are actually quite similar in their conclusions. The ESCMID guideline, as I said, goes more into the details and applies everything to the different patient groups, so it's a bit more differentiated. You can also see the ESCMID guidelines covered a lot more different types of tests than the others did, but in many ways they are similar. Also, the only thing you see is that there's a stretch from the B3 in the ESCIL guidelines for galactomania and BAL to the A1 of the IDSA, and the assessment of glucan is about as heterogeneous as probably amongst you, because I think there's really a lot of discussion going on in the community on what the value of that test is and whether we really need that. To go into more detail, we would have to spend a whole session, so I will just leave it at that and move on to prophylaxis and treatment. So for prophylaxis, it's actually very complicated, and I couldn't put everything you find in the guidelines on this slide because, again, some of them get deep into detail on the different patient situations, and it gets less and less comparable. But I think all guidelines agree that posaconazole is a good antifungal prophylaxis for certain situations, which is mainly AML-MDS. There's a difference. The ESCMID guideline says induction only. ECIL guideline says every intensive chemotherapy. IDSA guidelines is even less specific on the actual situation where you should use it. And then you will see there is a larger disagreement on the role of voriconazole, which again has quite a stretch from C1 in the ESCMID guideline to B1 in the ECIL and A2 in the IDSA guideline. And I would, there's another stretch in the assessment of itraconazole, but let's have a look at the voriconazole difference. So this is. I looked into all guidelines. They all quote the same two papers that are well known to you by Marks in the British Journal of Hematology and Wingard and Blood. And the first one comparing itraconazole to voriconazole, and the second one fluconazole to voriconazole in allogeneic stem cell transplant recipients. And this is basically what they saw. There was a slightly lower rate of IFD in both studies in the voriconazole group, and a slightly higher survival for the voriconazole group in both studies, but in both cases it was not a significant effect, and you could argument that the clinical difference is probably low between those drugs. However, the effect is there, it is visible, and it is plausible, and you could also argument this is an issue of power. The trials were not sufficiently powered to really show significance of that effect, and you can say, of course, it's probably at least as effective as fluconazole. So I think, and these are the different takes you can have on that evidence. So you can say it seems better, voriconazole, but the power was insufficient. And the conclusion of that would be, okay, I give it an A recommendation because it's better than the old standard fluconazole, but the trial was not properly designed. So I downgrade these basically A1 randomized trials to A2. And this is what, I don't know if that was their way of thinking, but this is the result of the IDSA guideline. You could, of course, also say you have two randomized trials, and they show a slight advantage for voriconazole, so I say this is a grade 1 evidence, but it's not a very strong recommendation because it wasn't much better, and you give it a B1, which is what ECIL did. Or, of course, you can say I have two randomized trials, they missed their endpoint, so there's no recommendation for the new drug. I have strong evidence that it's not better than fluconazole, and so I give it a C1, and this is what the ESCMID did. I think no one is wrong here. It's just on how you go, on how you look at it, and I think everybody has to think for himself what he thinks is the appropriate way of handling this data. Okay, this is empirical treatment. I think there was strong agreement here between all guidelines. There was one question whether it should be used at all as a strategy. The ECIL didn't find it as important as the others to use empirical treatment strategies, but if you use it, they mostly agree that caspofungin is a good choice, and liposomal amphotericin B is another one. Yeah. Now, regarding first-line treatment, and that's one thing more, where we could have a small discussion. At the first look, it looks great. It looks very, very similar. A1 recommendation for voriconazole in all guidelines, and then a recommendation for isovuconazole following Johan Mertens' study, and so it looks really nice. There's some disagreement on the role of liposomal amphotericin B, which is a trial that is difficult to assess because it was never formally compared to the old standard drugs like conventional amphotericin B or voriconazole. But there is one important issue from my perspective, because the ECIL guideline, the recent one, added a footnote to the voriconazole recommendation, and they said only with therapeutic drug monitoring. And this is something I actually stumbled over at first, because if you look at the two large randomized trials, the one comparing voriconazole to conventional amphotericin B by Herbrecht, and the other one, as I just told you, from Johan Mertens, comparing voriconazole to isovuconazole, and these are really the large trials that tell us on how effective voriconazole is and on how the tolerability of voriconazole is in these patients groups. You will notice that in both trials, and this is a copy from the method sections of both trials, they received a fixed dose of voriconazole, which is the labeled dosing. There was no therapeutic drug monitoring. And it was this very scenario where we saw that isovuconazole was indeed non-inferior to voriconazole, fixed dose voriconazole, and of course, as you know, a bit, it was more toxic than isovuconazole. So I think this is the information that we have. Voriconazole is more effective, better survival, better tolerated than conventional amphotericin B, and it is as effective but less well tolerated than isovuconazole. And I think these are the conclusions that I see as a possibility. The one being, okay, I have a nice randomized trial where isovuconazole was non-inferior, so I give both a straight A1 recommendation. You could also say isovuconazole was non-inferior, but it is better tolerated, so I wouldn't have been surprised to see one of the guidelines downgrading voriconazole to a B1 recommendation, but that didn't happen yet, at least. And of course, you could say, and I think this is probably what they did, but I think to me this is a little stretch, because it's based on assumptions that you say voriconazole was more toxic, but with TDM that could be managed, and so we provide that footnote and put the A1 recommendation on the condition of TDM, and I think that is, at least that should be more clearly explained in the paper. So that would be a careful criticism. Treatment of the duration of treatment, well, we all know there are no studies, unfortunately, that could guide us, and probably for that reason, in the ESCMID slide set, you find some overall considerations that I think are probably not really helpful. The ECIL guidelines, I didn't find any statement towards the treatment duration, and the IDSA, well, they said 6 to 12 weeks, and then mentioned some things you might consider to determine, but it's not really a clear pathway you could follow as a clinician. For second-line treatment, the ESCMID guidelines, the ESCMID slide set didn't provide those for adults, but the ECIL guidelines at IDSA are mostly the same. They just rated the quality of recommendation a bit differently, with the ECIL always saying, always giving a B recommendation, the IDSA always giving a strong recommendation. Both are not too keen on combination treatment. I did the same for candidemia, but I would be breaking my time. That just to briefly show you that I took that effort and to show you some of the differences. For diagnosis of candidemia, there was some disagreement on the value of antigen-antibody diagnosis. For treatment, there was the fluconazole use in the ESCMID guideline was rated as C1, while it was still A1 in the other ones. So that was a finding there. And for neutropenic patients, all guidelines were pretty much similar again. So as a conclusion, I think there was really a high degree of agreement between those guidelines. The topics as well as the conclusions that were drawn, all of the guidelines are very comprehensive and up to date and provide information that you need. I think one thing, of course, we all wish for evidence-based medicine, but of course, if you have all these experts in a room and discussing, I really would, my wish would be that some of the guidelines would be more brave in making recommendations on issues we don't have evidence about. I mean, after all, these are the experts. If they don't guide us, who will? And so treatment duration, response assessment, definition of treatment failure, when should I perform a biopsy? I think these are things I would hope to find in the future guideline. And of course, there is some risk of bias by the methodology by having, in the end, handpicked committees and involving people reviewing their own articles and not having a systematic literature search. Okay, thank you for your attention.